King Faisal Hospital in Saudi Arabia. Welcome.
Okay.
Mr. Chairman, I would like to thank the organizing committee for this opportunity to be in Kuwait and present number 5 maybe. Yeah. Yesterday, Dr. Caldwell presented to us some of the nice pictures that presented his country. And I think one of the main issue of the international meeting is knowing each other socially. I can read what Dr. Wallace wrote over the internet, but socially we cannot interact over the internet. So I come from Saudi Arabia, I come from Medina, and this is the view from the space, from the air. This white spot is the Holy Mosque of Prophet Muhammad, and this whiteness is not digitally made, it's just seen from the space. I would like also to thank the organizing committee for introducing to us this slide. This is the first time that I present in an international meeting a disclosure, and it is nice to present our disclosure. I would like to introduce to our colleague that we are not far from each other, because we have been making disclosures for the past 1400 years. And it really comes fascinating when you read in Arabic Muslim books what Muslim physicians as well as surgeons wrote about this matter. And it even to the extent that I will translate only this one, that they say, even if you can pay from your own pocket to the poor, please do. They made a lot of contributions, so I will skip this one, but we have a lot of material, so please, if you are interested, ask me after the presentation. So let's go ahead and see some neurosurgery. Now, in 1996, about almost 10 years ago, I was sent by my teachers. Some of them are here now, Dr. Abdul Wahab Ibrahim and Dr. Kanaan, I don't see here, who yesterday said that my colleagues are sitting in the audience. Actually, we are his students. I was sent to learn endovascular neurosurgery, and as was asked by Dr. Chioka, that will you send your resident to learn skull-based techniques or endovascular techniques? Actually, I went to learn both. The skull-based vascular technique, microsurgically, as well as the endovascular techniques. As was presented now a few minutes ago, when I started, the issue was of whether endovascular or microsurgery, clip or coil, and fighting was there. We worked in the microsurgical improvement, as did the other colleagues, in improving the instruments as well as introducing new techniques and approaches. Now, on the other hand, we also worked with the endovascular team in improving the coils, but not only that, in improving on new technologies that were not there 10 years ago. Now we are 10 years later, and we are still the same question, clip or coil. And here I present the first slide of disclosure, that I think one of the main issues is financially. A microvascular does not want to give up microvascular clipping, and endovascular wants to bring this issue as the best in life and nothing else, and all aneurysms should be done endovascularly. But how far did we go? let's see. Now I learned that some of the aneurysms, as an endovascular neurosurgeons, having both tools in your hand, some of the aneurysms are technically relatively difficult to reach. A basilar tip aneurysm, especially in the acute stage. Well, with the endovascular technique, this is just a highway. You can introduce your microcatheter, you reach the aneurysm, and then coiling in a short time. On the other hand, a aneurysm that is in a location relatively easy to approach, easily exposed in the Sylvian fissure, but sometimes the angio architecture itself does not suit for an endovascular approach. So in your hand you have both tools, and you can say that this aneurysm should be clipped. Now I should conclude. We should stop fighting and saying clip or coils, clip or the new endovascular techniques of coiling, clip or neck remodeling, stent, intracranially stent introduction, and so forth. We should work in collaboration. Now the best collaboration of the person himself, collaborating with himself, having both tools in both hands. On the other hand, especially in our areas, and definitely in other parts of the world, endovascular techniques are not always available. So we should continue knowing the microsurgical techniques in treating these pathology. Now, moreover, the surgical techniques have improved. The neuroanesthesia have been different than 10 years ago. The ICU management is totally different and improved. So all of these will add to the outcome of the microsurgical techniques. So in conclusion, we should continue in learning as well as teaching the microsurgical clipping of aneurysm. At the end of the day, what matters is the customer satisfaction. Now, let's rise and see some of the MCA aneurysm points that are related to it. As with the other aneurysms, most of the MCA aneurysms present with subarachnoid hemorrhage. And as I just said, in our area, almost all of the aneurysm present with subarachnoid hemorrhage. And most of them are of the small size group. Some of them, they present with an intracerebral bleeding or even subdural acute bleeding. They constitute about 20% of all intracranial aneurysms. And depending on the, did we bring here a pointer or not yet? No. So depending on the location you see it, then it is classified into proximal bifurcation, typically location, or the distal MCA aneurysms. Now they can be a simple saccular aneurysms that are easily to be managed by both clipping or by endovascular technique, namely coiling, or they can be difficult for both to manage, like in this case of a fusiform aneurysm that is involving almost all intracranial territories, both anterior and posterior circulation. The middle cerebral artery aneurysms can be simple non-thrombosed aneurysms, or they can be with a various size of thrombus. And from here, you have to choose whether you would like to put a coil and then after 6 months it might compact, or you would like to reconstruct and put a clip. Now, having decided to use the microsurgical techniques, the arterial vasculature or architecture is not the only thing that is important, But the venous structure is extremely important in knowing what does this particular patient have with his Sylvian veins, because the approach mainly entails opening the Sylvian fissure. So the type of the Sylvian veins are extremely important and will add to the outcome. Now, operating on a patient with no vasospasm to start with is much easier and more rewarding than operating on a patient with a vasospasm on the spot that he presents. And not unusual that in our regions we receive the patients not on the first day, and we receive the patients in the days that it says to be the time for vasospasm, and then no act should be done. Now, multiplicity is not unusual in MCA aneurysms, and as an endovascular neurosurgeon, you have to decide whether these are suitable all, as was just said, by the endovascular techniques, or they can be approached all by a single surgical exposure, or sometimes you need, as was also presented, you need to treat some with the endovascular and the rest with the clipping, like in this case, a middle cerebral artery and a pica aneurysm. Now, middle cerebral artery is a nicely exposed aneurysm, but in not a small number of cases, branches are involved, and sometimes main divisions of the MCA are involved in the aneurysm itself. So from the endovascular point of view, sometimes I find it extremely difficult to think that our colleague, the interventional radiologist, they would like to do it with the endovascular management. Now, converting a simple procedure into a real difficult and complicated endovascular techniques of having remodeling of the neck, inserting stents, inserting balloons, and inserting double or three guide wires. Okay. The distance or the length of M1 also matters, because I have to know before approaching the middle cerebral aneurysm how far I am going to dissect through the Sylvian fissure. There is always a debate whether to remove the hematoma and clean the subarachnoid space totally, or you limit your exposure so that you will not irritate the vessels. Now, bringing the patient to the OR, more than any other pathology, an acutely ruptured aneurysm needs a perfect position. A wrong positioning of the patient might convert a simple procedure into a dramatic, complicated one with brain swelling and brain edema. Always try to no retractions at all, or minimal, especially in the management of the acute stage subarachnoid hemorrhage ruptured aneurysm. In most of the time, I cannot do it without putting a retractor, but not putting a retractor throughout your surgery. You have to intermittent, and you have to perform some of the techniques that will eliminate or reduce the amount of retraction that you will perform, like drilling of the Sylvian fissure, so that you will limit your retraction. Now, as we said earlier, opening the Sylvian fissure, looking for the arterial tree and the aneurysm itself is important, but more important, we have to respect the draining veins. In the acute stage, you will be faced by a hematoma, organized sometimes in a certain degree. So opening the Sylvian fissure might not be easy. but a slow performance or a slow progression can let you know which Sylvian feature you are following, whether it is a zigzag, it's corrugated, or it's a straightforward, rather than quickly sucking the hematoma and then facing that you are touching the what is called the angry brain. If the aneurysm is complex, then it is complex to be managed by both endovascular and microsurgical techniques. And here, what collaboration really means. Now, dealing with a complex pathology or aneurysm, we have to train ourselves on using a single clip in closing the aneurysm, in using multiple clips to fashion the aneurysm neck, or we have sometimes to know how to perform a bypass procedure just in case you had some trouble during procedure, or sometimes as a planned procedure before you tackle the aneurysm itself. Now, I conclude really by saying the same in the beginning, that going for a training involves both microsurgical techniques and endovascular techniques might be the solution, inshallah, and customer satisfaction. I think it's time now for me to sit down. Thank you.